Hello everyone. Now we'll discuss question of neurology. So we have a 10-year-old girl and she presented with progressive dysarthria, ataxia, horizontal nystagmus. On examination, she had upper limb muscle wasting, especially small muscle of the hand. Lower limb deep tendon reflexes are absent. She had bilateral extensor plantar with loss of joint position and vibration sense also. Well, what's something unique we are noticing in this question? We are finding the deep tendon reflexes are absent. This is a feature of lower motor neuron palsy, very obvious. But we are also getting extensor plantars. This is a feature of upper motor neuron palsy. This point has to be noticed right now. Okay, let's see. There's a loss of joint position vibration sense that we know very well. They are carried by posterior column. Okay, so we are getting something, a mixed picture we are getting in this patient on clinical examination. Right, sir. Again, muscle wasting, again indicate lower motor neuron palsy. Nystagmus is usually related to something with cerebellum. Well, this is what we have, including dysarthria. There are all some cerebellar feature we are getting in this patient. Interesting question. Most likely diagnosis is, well, if you look into this, what are the things which can involve everything, including cerebellum and other thing also? The best answer to this question is Hydrocatexia is the best answer. So why this? What are the features of Hydrocatexia? It is characterized by progressive limb and gait ataxia, absent lower limb tendon reflexes. Okay. It can be early onset of symptom at the age of 5 to 15 year, or late onset may occur in 20 to 30 year also. Well, in our case, the age is 10 year. That means the early onset type of problem is there. Well, it has equal sex incidence. Our case is a female. She's a girl, 10 years girl. Well, genetic mutation responsible for GA tied nucleotide repeat expansion of FXN1 gene, and it is on chromosome 9. Okay. Well, unless we know the basic pathological changes in Hydrocatexia, you will not understand why these clinical features are there. First of all, there is degeneration of spinal tract, which are the degeneration of posterior column, and that's why we got position vibration sense. V vibration sense was lost in our patient also. Pyramidal tract, it is due to this that we got extensor plantar. We are getting spinocerebellar features. That's why we are getting ataxia in this patient. There is a degeneration of peripheral nerve. That's why deep tendon reflexes are diminished despite involvement of pyramidal tract. So that's why we are getting a mixed picture of UMN and LMN, and this is the one which is going to cause feature of lower motor neuron palsy, muscle wasting due to all these things. Well, there may be slight atrophy of cerebrum and cerebellum also, but not a major issue. Cerebellar atrophy, optic atrophy is a feature, important feature in this case. Now, if you look into the finding, we are getting involvement of posterior column, we are getting corticospinal tract, peripheral nerve, and optic atrophy also. Okay, so now my question is, these findings, what I just mentioned, that these findings we can see in the deficiency of which vitamin? Well, stop the video, write down the answer. It's a simple question. The answer is vitamin B12 deficiency. Okay, so we are clear about it. Can it be a case of, can this happen in multiple sclerosis also? Yes, in multiple sclerosis, peripheral neuropathy is not a feature. They may have posterior column, they can have pyramidal tract involvement, there may be spinocerebellar also, the optic atrophy is there, but peripheral nerves are not involved because multiple sclerosis is a disease of CNS. It is not a disease of peripheral nervous system. Okay, so we are clear about it. We move further. Well, now classically in this spinal cord is involved, especially the cervical part. What is that? I'll discuss in a minute. There is cerebellum involved, heart involved, peripheral nerves are involved, which can lead to atrophy. Okay, of the muscle. Let us see what are the signs and symptoms that we see in these patients. First is slurred speech. This is due to involvement of cerebellum. Curvature of the spine, so-called scoliosis, is a feature. High arch, plantar arch, so-called pes cavus. Deformity of the foot. Diabetes can be there, that means hyperglycemia. Heart disease like atrial fibrillation and dilated cardiomyopathy can occur in these patients. Okay. Well, when we try to diagnose, we have to document axonal sensory neuropathy. EC shows left ventricular hypertrophy. Now, MRI will show shrinkage of cervical spinal cord. This you can see. This is the classical finding you can see in this. This is a finding that we are getting it. MRI. Well, now we learned that in this case there is triple, this nucleotide repeat expansion triple. Now stop the video, write down the answer, tell me some other disease where we have triple trinucleotide repeat expansion. Other diseases are Fragile X syndrome, Huntington disease, spinocerebellar ataxia. In fact, this happening. This itself may be a finding in hydrocatexia also. Myotonic dystrophy and myoclonic epilepsy type of thing. They have triple nucleotide repeat expansion. Now let's look into other option. Motor neuron disease not affect the sensory system. Okay, there is no involvement of posterior column, so this is ruled out automatically. Cary malformation is a condition in which brain tissue extends into the spinal canal. It occurs when a part of skull is mishapen and smaller than the typical, pressing on the brain and forcing it downward. Cary malformation are often identified incidentally because most of the time they are asymptomatic. But symptomatic type, they can complain of headache, particularly induced by coughing and sneezing, which is not there in our patient at all. And look into this. This is the typical thing. What we can see, look into this, cerebellum is getting herniated into the spinal canal. This is a typically Cary malformation. And this is a much better picture. Look into clear picture. You can see this is coming down into the spinal canal. And when you treat, what you do, you simply remove a bone piece and now you make it wider. Make it wider, so now it goes back. So we do the decompression to be more precise. This is a surgical treatment of so-called Cary malformation. Now, I have one more question for you. Cary malformation are often associated with which other condition? Stop the video, write down the answer. Well, development of syringomyelia. In such cases, upper limb weakness and suspended sensory loss to pinprick and temperature can occur. This is so-called cape-like distribution of loss of sensation in the upper limb and the lower part of the cervical area and the upper part of the chest that we see. Now, what are the most common site of syrinx and what are the MRI finding in syringomyelia? Stop the video, write down the answer. I've got 2 extra questions for you. Well, we get a cape-like distribution of the pain and temperature loss. Why the syrinx is there? It is the expansion of central canal and that causes involvement of bilateral spinothalamic tract. That's why especially it causes loss of pain and temperature in this part of the chest and of course in the limbs also. Well, in MRI we get bubble in cord appearance. The classical finding we get in these patients, bubble in cord. Okay, you can see this bubble in cord appearance. And the most common site is lower cervical and upper thorax. Upper thorax is the common site where we have this problem. Well, option C is multiple sclerosis. Prominent muscle wasting is not seen. Why? Why muscle wasting does not occur in multiple sclerosis? Stop the video, write down the answer quickly. Because multiple sclerosis is a disease of central nervous system, CNS. It is not a disease of PNS. So that's why muscle wasting is never a feature in these cases. Subacute combined degeneration of spinal cord, degeneration of corticospinal tract, posterior column may cause weakness and sensory as described in this case. However, brainstem sign, dysarthria, nystagmus are not the feature of subacute combined degeneration. Cerebellum is not involved. Golden line to remember, Hydrocatexia is an autosomal recessive inherited condition. The genetic mutation responsible is GA, trinucleotide repeat expansion in FXN gene on chromosome 9. Thank you very much.